1 out of 4 women can have pelvic floor disorders. Often, though, women are too ashamed or too embarrassed to talk about pelvic floor disorders, so they may not mention it to their provider, their primary care physician.
Sometimes the pelvic floor disorder is overlooked, and a lot of these patients, men and women, suffer in silence for years. The important thing to remember about pelvic floor disorders is that they are not localized to the anterior compartment of the posterior compartment. Some doctors focus on the front and some doctors focus on the rectum and the back, but the pelvic floor is one entity.
The Center for Pelvic Floor Disorders at Mass General Hospital started in 2009 when a team of doctors, surgeons, providers, physical therapists came together to form a collaborative, multidisciplinary group to take care of patients with pelvic floor disorders.
It is not easy to bring all of these busy specialists all together in one room, but I think we all realize the value that we get from each other, the feedback, the interaction that we have.
Patients are typically referred here for a whole list of different complaints. We deal with patients with bowel dysfunction. We deal with patients with urinary complaints. We deal with patients with vaginal prolapse complaints. We spend a lot of time with them really talking through and making sure we're touching on all of their symptoms. This allows them to kind of open up and talk about things that they may not have talked about, making sure that we address all of the concerns that they have.
I went through a period where there was a degradation in my bowel functioning. It was terrifying because you don't know what's going on. But what was incredibly helpful is that I had this team of professionals that did know what was going on. I knew they were going to focus on my whole body and the whole person, and it wasn't an isolated issue, and they were able to explain that to me.
When we first met Allie, she was underweight, not feeling well, not doing anything that she wanted to do. And with the team, we were able to put our heads together and try and figure out the best course of action.
I was so blessed. I had this incredible team of doctors that really held me and worked together and understood the complexity of what was going on and collaborated and had conferences. Everybody was communicating together, which was so helpful to me.
The providers that are involved in the review process are all of the physicians and providers, including the physical therapists. We're all sitting in the same room. We're looking at all the images, the defecographies, the MRIs, and so on, all together. When we decide patients need surgery, and if they have problems both on the vaginal uterine side, the GYN side, or the colorectal side, we can do their surgery under one anesthesia and the patient can have one recovery. It's better for the patient and lower risk for the patient as well.
If the patient needs collaborative surgery between the urogynecology side and the colorectal side, we want to make sure that kind of those collaborative surgeries make sense and work together. Sometimes one of us starts and kind of allows for another person to come in the middle. Sometimes we work together simultaneously. It depends on a case and depends how we do it.
When you have services that are working together, then it saves the patient that extra time in the OR, and it's getting done all at the same time. So it leads to better outcomes, better patient satisfaction.
One of the other things that we can do is basically use some of these new extraction techniques for removing pieces of colon through the vagina, for example, which is not usually done, but all of this is done just basically to make them return to their normal activities as soon as possible.
Often urologists and urogynecologists will overlap, but when the problems become more complex with the bladder issues or with kidneys, that's when the urologists come in and help out.
Urologists have a big role to play in the pelvic floor center and pelvic floor disorders because we actually share the pelvic floor with the bladder and the vagina and the whole pelvic floor itself, even including the rectum.
The pelvis is kind of like a car engine. All the parts work together. So when we approach the patient, we approach in a holistic manner.
We're excited that we have a partnership and we have partners that are willing to work with us.
It's a great feeling taking care of patients in an environment where you know they're getting the best that you and your colleagues can provide for comprehensive needs.
Patients with colorectal pelvic floor disorders usually have a combination of symptoms of constipation, fecal incontinence, and prolapse. And that's why gastroenterologists are a key part, sometimes for years to come afterwards.
Our role as gastroenterologists is first to help in the medical management of the problems. This would include medication changes or additions. It would include diet recommendations. Management also includes psychosocial aspects.
For a patient who's seen in the Pelvic Floor Disorder Center, when we talk about these patients in a group setting, we can really learn a lot about what sort of things we can expect, how can we prepare our patients, and how we can do a better job in terms of the after-surgery period.
After surgery, patients sometimes can face significant challenges.
We still need the physical therapist to try and get them to where their quality of life is restored.
When it comes to pelvic floor disorders, what we find is that medication and surgery are not always the only answer. You have to get the muscles in the area to function properly. Otherwise, you can have perfect meds and perfect surgery and still not have the area function correctly, and the symptoms can be just as bad as they ever were. One thing we do a lot in physical therapy is working on muscle coordination. And in the case of somebody who has had surgery to correct a bowel disorder, we have to make sure that the muscles are not overly tight, not overly weak, and then coordinating properly again to pass those bowel movements.
When we meet these patients, they are devastated, they are ashamed, they are sad. We feel that when we team together and we use our expertise, we shorten the entire recovery course by being coordinated.
We can do things to get their quality of life better, and they end up being happy. And to be able to do that for patients is a huge privilege.
When you aren't able to eat, when you have to have NG tubes put in, these are terrifying, terrifying moments. And I felt like my team through everything was just unbelievably skilled and competent. I just felt incredibly cared for.